Good evening, everyone. My name is Dr. Karen Carrasquillo. I'm the VP of Clinical and Professional Affairs at Boston Site. And I'd like to welcome all of you to tonight's webinar titled Mastering the Art of Scleral Lens Fitting Evaluation, the Importance of Photo Documentation. Tonight, we have two very special speakers and top-notch experts in the specialty contact lens field and in scleral lenses. We have with us, and we're very honored and very grateful to have Dr. Shalu Pal and Dr. Avani Dave. As a matter of introduction, Dr. Pal is currently the owner of a group practice in Toronto specializing in advanced specialty contact lens fitting, dry eye management and treatment, concussion rehabilitation, vision therapy, and ocular aesthetics. She graduated from the Southern California College of Optometry and completed her contact lens, cornea, and disease residency at Northeastern State University, Oklahoma College of Optometry. She's a member of the Global Myopia Symposium Planning Committee, an advisory board member for the Global Council of Myopia Management, and an editorial advisor for the Review of Myopia Management. She's a member of the research study group Myopia in Practice, and she's a member of the New Technology Committee for the American Academy of Optometry, and I should say, the past chair of the American Optometric Association Corneal Contact Lens section. She's a board member of the Canadian Association of Optometrists Corneal Contact Lens section and co-founder of the Canadian Contact Lens Academy, which is hosting their first national contact lens meeting in Toronto, Canada. Dr. Avani Dave received her Bachelor's of Science degree with honors from McMaster University, where she then was awarded the Presidential Scholarship to attend the New England College of Optometry, where she earned both her doctorate degree in optometry and she also pursued a residency in corneal contact lenses, focusing on specialty contact lens fitting. Dr. Dave is currently the director of the Optometry and Contact Lens Service at the University of Buffalo's Ross Eye Institute. And as a clinical instructor for ophthalmology, she's involved in lecturing residents and enjoys teaching through her role as attending optometrist for both optometry and medical externs. She's also an associate optometrist at Dr. Shalu Pal's practice in Toronto. And I should say, actually, that Dr. Pal is one of Dr. Dave's mentors. So it's what an amazing honor to have you both lecturing together tonight. She's a member also of the Canadian Association of Optometry. And she's a fellow of the American Academy of Optometry and is currently pursuing her fellowship in scleral lens with the Scleral Lens Education Society. So without further ado, and before passing this on to you both, Dr. Dave and Pal, I just want to tell the audience that as we go through the presentation, please just submit your questions through the Q&A panel section. And as time allows, we will answer the questions at the end of the webinar. So I'm going to launch this in presentation mode. Dr. Pal, and on to you. Take it away. Thank you very much.
Thank you so much, Karen, for inviting both of us to be here together. We're really happy to be here and excited to chat with you guys. We really want this presentation to be very much a conversation. And you know, before I dive in, I just want to tell you a little bit about Avani. Avani was a third-year student when I actually first met her. I was doing a talk at her optometry school, and I kid you not, but she was just a shining star that stood out in the class. And I took one look at her and I said, she's going places and she's going to be awesome one day. And I want to one day work with her. So I quickly snagged her and reeled her in and made sure that she got to work in our practice. And I'm so glad that we are friends now, and you're doing wonderful, great things. And it's an honor to be able to lecture with you. I'm really excited that we're doing this together. So thank you so much, Karen, for bringing us together.
It's a pleasure. Thank you.
Let's see here. I'm trying to advance these slides here. There we go. So the topic that we're going to be talking about today is scleral lens fittings, as well as talking about the photography and how important it is. And we're going to go through a series of talking points, starting with just how do we evaluate scleral lenses, some key complications, and then looking at photography, why it's important, and how to take some good images. And then we're going to dive into a few cases. So let's just get started. And let's start with talking about the fundamentals of fitting scleral lenses. There are three main zones when we're talking about scleral lenses. We've got our corneal clearance, the limbal zone, and the scleral landing zone. Now, I started fitting scleral lenses, oh my God, it was 17 years ago when I started learning about scleral lenses. And back then when we were dealing with scleral lenses, you know, when you made a change to one curve, everything changed. And so when I started learning, my philosophy was to start on the outside and work my way in towards the center. And that strategy worked for a really long time. And I know, Avani, that if I ask you sort of what your strategy is, I'm not sure if you're doing
opposite. Yeah, so in the world of, you know, recent scleral lens fitters, we all know that the first thing we do when we put a scleral lens on is we look to see is the scleral lens truly vaulting the cornea. And so my strategy always is starting in the middle of the scleral lens and working the way out. So it's interesting that the two philosophies, we do the same thing, but we have different methods to really evaluate different zones.
Yeah, absolutely. It's funny how that philosophy has changed over the time, as well as now, you know, the independent curves and the way they all work together independently, where you can change one curve, and now when you make one change to one, the whole thing doesn't change. That's really changed the perspective on how we actually fit. Now, if we dive in and start looking at corneal clearance being the first thing that we look at, there are a couple of different ways that you can evaluate corneal clearance. And when we start just with the initial putting a lens on the eye, if you put a little bit of fluorescein into the bowl and then put on the eye, that makes it really helpful for you to be able to take a look at this central vault. With the fluorescein, having a retin filter in there is a lot more easier for you to be able to see the different zones, and it helps you to really bring that fluorescein to help it pop. What I usually do is I take, and I like to know what the thickness of my contact lens is. So with the Boston Scleral lens, it is 250 microns in thickness. And I use that as a reference point to take and compare what the actual thickness is of my clearance is. I did this all by slit lamp before my OCT came about. And then once I got my slit lamp, that was really the game changer for me, because now it wasn't so much guessing and using these estimates. I had a very, very specific tool for me to be able to make these exact measurements. With the OCT, we can have these beautiful diagrams of what the cornea looks like, what that scleral space is, what the scleral size is, and we can use these rulers to actually take these measurements, which is fantastic.
Shalu, here's a question for you. At what point do you actually evaluate the central clearance of the scleral lens after you apply it on the surface of the eye?
Yeah, it's a good question. So when I initially put a lens on, I want to very quickly do quick 3 scans of the cornea to see, okay, do I have touch anywhere? If I don't have touch, then I'm going to be able to go right ahead and let that lens settle. And then I'll wait a good half an hour, 40 minutes before I'm going to take a look at that lens again. If I've got touch, then I'm going to change the lens until I have a lens that has enough clearance before I allow the lens to settle. How about you? What do you do?
So I think in an ideal world, I would love for a lens to settle at least an hour on the eye. There's a great study that was done at Fair State that looked at a particular diameter of a scleral lens. And what they found was that the scleral lens settles the fastest in the first 20 to 30 minutes, and then about 50% at the hour mark, and then really a large majority after 4 hours. But unfortunately, practicing in Buffalo, I'm in a high volume ophthalmology practice, so I don't have the luxury of waiting an hour for the lens to settle. So usually I allocate at least 20 to 30 minutes before I'm really finalizing what I would assess to be my central corneal clearance to be.
Yeah, it's, you know, it all kind of depends, you know, on the particular day. I very much often do try and get that good hour, and I do that by, you know, warning my patients ahead of time that this first fit that you're going to be with me, you're going to be with me for a couple of hours. So to plan for that. And, I guess in private practice, we do have that luxury of being able to get that full hour before we do get to settle. I think the key thing when you're looking at corneal clearance is to make sure that you don't just look at the center. And I have this sort of diagram right here where we have a scan right across the center. You want to make sure you look at all areas of the cornea. I have it set that we do 5 measurements throughout the length of the cornea, just to make sure, because when you're dealing with irregular corneas, you're not dealing with an even cornea where you're going to get that same amount of coverage from top to bottom. So just make sure you look at all areas of the cornea. And last thing to ask you, Avani, for you, what is your ideal height that you're looking for once the lens has settled, whether that's 1 hour or the 4-hour mark? What are you aiming for?
That's a tough question to answer because nowadays there's so many different philosophies. I think when I first started fitting sclerals, it used to be about 3/4 to 1 of the thickness of my diagnostic lens. And there's a great study by Mashad that looks at, combining the tear meniscus height and the central corneal thickness and using the 150 microns and the 250 lens thickness to really kind of balance and optimize oxygen permeability. So to answer that question, really what I'm looking at is maintaining a nice, even, but low tear meniscus height to optimize oxygen. And it really just depends on the cornea. I mean, a cone is going to look very different than a regular, dry ocular surface oblate or prolate cornea. So it depends on the eye.
Yeah, it's so true. When you have a cone where you have a 50, 60 microns at the top, and then you've got an edge clearance of 500, 600 microns, it's hard to get that even pattern all the way through.
Exactly.
It's true. It's true. I think my goal is to monitor closely when you're dealing with these corneas and make sure that whatever height that you have, you're not doing any harm, and that you just make sure that you don't end up with any touch.
Yeah, and I think that's a great point. So why we're even giving this lecture is how to monitor and identify it. So moving on to the second fitting, technique of scleral lenses is the second zone, which is the limbal zone. So the limbal zone is that transition from your cornea to your sclera. And we all know that the limbus is the home of your palisades of Vogue and maintaining that integrity of your cornea through the limbal stem cells. And so here, there's various techniques to evaluate your limbal clearance. If you do use the method of putting or instilling sodium fluorescein into your lens bowl, put up your retin filter and turn that cobalt blue light on and really assess the scleral similar to our rigid gas permeable lenses. Look for either bearing where you have minimal corneal clearance at the limbus, or whether you have excessive clearance using your fluorescein pattern. Also, for me, slit lamp evaluation is key. It's interesting because with the slit lamp, no matter how high you go on the magnification, it's said that the human eye can only really appreciate about 15 microns of clearance at the limbus. So oftentimes, really, using an OCT can really give you confidence and trust in yourself as a fitter. And the goal with limbus is that you want to maintain a nice low profile of the corneal clearance at the limbus to make sure you're not doing any harm to those stem cells. So the question then becomes, Shalu, is what's that ideal height?
Yeah, it's a really good question. I think I aim for 40 to 60 microns. But again, I just want to make sure I'm not doing any harm. This image that you have here, Avani, right here, where you see this dark band here at the limbus, this is tricky because this can be really deceiving, because you could look at that and say, hey, I've got touch at the limbus. And what I love is now having the ability to have the OCT where you can actually scan and see exactly, do I actually have touch or not? And 50 microns, it's a small amount that, it's hard to appreciate sometimes on the slit lamp. And, that OCT really helps you to really see whether you truly do have touch or not. So when you do see an image like this, where it looks like, there is some touch at the limbus, you take another closer look and see if it truly is there.
I agree. What else is also interesting is we know that gravity plays against us. And so oftentimes scleral lenses, with the way they settle, it tends to be inferior temporal. And so really evaluating the limbus in all positions. It's not just superior temporal nasal, but also all 360 degrees. And the beauty of the Boston Sight Scleral is that you have quad specific zones that you can really manipulate. And for me, I often will sometimes forego slightly higher inferior limbal vault as long as I'm verifying that I'm not doing more harm, just simply because I know gravity is working against me.
Absolutely. Absolutely. So the scleral landing zone, this is the outermost edge of the lens. So, you know, for me, this is the most important zone of the whole thing. This is what really determines how this lens is going to fit. This determines the comfort of the lens. You can evaluate this initially where having you have the sodium fluorescein in the bowl of the lens, or you can evaluate it after the lens is settled by putting fluorescein on top of the lens. How you do this, and there are many different ways. Some people would paint fluorescein onto the surface of the lens. Some will put it at the superior conj and let it drain in. The purpose of doing this is for you to be able to see the edge of the lens and see how is fluid moving in? How is that sodium fluorescein moving under the lens? Is it getting under at all? How high is that edge? And you get to see the rate of exchange that's taking place. Both having that fluorescein in the bowl versus putting it in afterwards are going to give you two totally different pieces of information. And I think both of those pieces are really important when you're evaluating the scleral edge. I don't know about you, Avani, but I'm not using lissamine green as much. It is a very good diagnostic dye to be able to see and highlight the edge of that lens really, really nicely. Are you using it often or regularly?
Yeah, so I actually use lissamine green on a regular basis, and primarily because with especially lenses like the Boston Sight Scleral, where we're dealing with large diameters, we're probably going to run into some architectural, diversions, whether it's a pinguecula, whether it's a tube. And so really for me, lissamine green is a great way to see what that scleral lens landing zone is doing to the conj. And it's a great way that when you may not necessarily appreciate blanching, you can pick it up because really the dye does not lie.
Yeah, it's true. It's really, really true. A key point that you've mentioned is about looking at the conj, taking the lens off, putting dye, whether it's fluorescein, whether it's lissamine green, onto the cornea, onto the conj, so you can see what is actually happening underneath the lens, and if that lens edge is creating any irritation or causing any problems to the conj. If you don't take that lens off and you don't take a look, you're not going to be able to find some of the issues that arise. Last thing to take a look at here is the OCT. The OCT is really helpful for you to be able to take a look at that edge, whether the edge is lifting, whether it's really diving in, or whether you have that nice landing. Avani, you mentioned it, the architecture of the sclera. One of the things that we know about the sclera and the anatomy of it is the closer you get to the limbus, the more dense or solid and rigid that sclera is. The further away from the limbus, the softer, spongier it is. When you're dealing with a larger diameter 18 millimeter Boston Sight scleral lens, you're going to deal with a lot more irregularity. So you're going to need to make some more changes to that edge design opposed to having a much smaller lens. But you have the ability to have quad specific changes, and you can make those alterations by having those quad specific designs. You have the ability to make notches, use channels, fenestrations. And one thing that we mentioned before is that these curves are all independent. So when you make a change to that edge, it's not going to affect your base curve, your sagittal height, or the limbal region at all. One of the images that I really like is this, where we look at what a perfect takeoff landing should look like a scleral lens. So I always keep that in mind when I'm taking a look at it. And one of the last things just to mention is that your patients are really key when you're evaluating the landing zone, because before I even look at the landing zone, whether it's with the OCT or the slit lamp, I'm asking our patients, how do they feel? What do they feel? Because they're going to guide us to areas where that lens is lifting and where the edge is lifting. And that really helps you hone in on areas where that you need to take a closer look at.
Yeah, I couldn't agree more with you. So I think that the next slide, Shalu, actually shows an excellent resource. And I encourage anybody who's a new scleral lens or even a seasoned scleral lens fitter on this call to really utilize this resource designed by Ferris State, where it allows you to see the variations of central vaulting, limbal vaulting, and really understanding that edge relationship. When I first started practicing, I actually used to keep this up on my desktop, and I would use it as a comparison of looking at a lens that I had on POS on a patient and comparing it to a standard. And so this is a great resource. It's available on the Gas Permeable Lens Institute website, and I definitely encourage all to really utilize it in practice. So, Shalu, we've now understood the fundamentals of scleral lenses as far as the fitting 101. Now let's start understanding each zone and determining when you end up at a point where you might have a complication based off of each zone. So when we first think of our central clearance zone, what we're thinking about is either you have too much or you don't have enough. So there's a big discussion, and this is probably a lecture for another day, of corneal edema and how much is actually inducing corneal edema. But the goal for us as practitioners is not only to be fitting the lenses, but also to be looking at the eye that you're managing and treating. So corneal edema is one of those complications. Personally, for me, I like to take baseline pachymetry readings, and then also during my fitting, as well as every follow-up, I'll take that lens off and get a pachymetry value. I find this especially crucial for corneas that are going to be more susceptible. For example, our corneal transplants. Corneal staining is an example when you don't have enough corneal clearance. And this is, where your dye becomes very helpful. So really looking for staining patterns and seeing if that staining pattern correlates to the area where you're questioning, is there enough clearance or is there not? Dimple veiling also is another great feature to look at on the cornea when you might have too much clearance. Discomfort, this is a great one when you're thinking about scleral lens and bubbles in that tear meniscus, because oftentimes we've all had patients that will come in for their scleral lens follow-up, and you pull that slit-lamp around and they're complaining about the comfort or their vision, and there it is, a big wonkin' bubble. So really identifying those bubbles, teaching and educating your patients, but also taking the lens off and staining and looking at how that's implicated your cornea. And then lastly, poor vision. So we obviously know that fogging is a big issue with scleral lenses, and oftentimes this can be due to the quality and quantity of your tear meniscus height. And a lot of this can be related to your corneal clearance. So one is assessing how much, but two is looking at the quality of that tear meniscus. How much debris, how much fog do you have in that, and how is it affecting your patient?
I don't know if there's anything I have to add to that. That was just perfect.
Oh, perfect.
When we take a look at the limbal zone, there are really two situations. Your limbal zone is either touching your cornea or it's way too far from the cornea. When you have touch, you're going to create damage to that limbal zone. You're going to have staining. It's going to create discomfort. When you have too much of clearance at the limbal zone, that creates this negative pressure underneath that lens, and negative pressure can create edema. It can create neovascularization at the limbus there, like you're seeing in that photo. It can also cause that conj to come underneath the lens and be pulled up underneath the lens. That's what we call conj prolapse. Whenever you see these things, you have to be thinking about the limbus, and our strategy here is to make sure you reduce the amount of limbal clearance that you have, again, aiming for that 50 to 60 microns and making sure you're not touching it all, because that's the area where all the stem cells are, and you don't want to make any damage to that region there. The best way to find out if you are having any issues is, one, make sure you look at your scans, make sure you use your good optic sections to scan over the limbal region, and take the lens off and stain the cornea to make sure you see what's happening there, and take a good look at the cornea without the lens on to make sure that there's no problems.
If you don't look for this short term, it's going to come back and haunt you long term. And we've seen this quite a bit with especially the neovascularization, where that eye is just crying for help. And that's, a source of really paying attention to that limbus. So the scleral landing zone, a lot of this is going to be associated with not only the fit of the lens, but also how your patient feels with their lens on. So part of it is the comfort, any discomfort, whether it's a pressure sensation because the edge is too tight on the eye, or an edge sensation where the patient keeps catching the lens. Really evaluating your scleral landing zone is crucial. Conjunctival staining, as I mentioned before, I use my lissamine green religiously to really look to see what the edge is doing to the eye. Also, rebound injection. I have a beautiful image of a patient below where the lens might look nice, quiet with it on the surface of the eye, but we've had many patients that will take that lens off and there goes all those blood vessels. Yep. And if you haven't seen it in the office, your patients will tell you about it. So that's another indication to really evaluate those scleral landing zones carefully. Shalu, you already mentioned the limbal vascularization, prolapse, and this is again all an idea that each individual zone we're talking about is not independent of each other for the corneal health. They all work as a system together, and so one zone of the cornea might affect the limbus or vice versa. And the same thing really happens when it comes to fogging, really evaluating whether your scleral landing zone has an edge that's really causing an influx of debris. Many of our patients also come in complaining of headaches or a pressure sensation. And while we don't want to ignore the optics piece, a lot of this might also just be related to how well that lens is sitting on the surface of the eye. Ultimately, this is a foreign body on the eye. So it's our job to make it as comfortable as possible for our patients.
One thing to remember too, we've both mentioned this earlier, is that this lens is going to settle the longer that it's on the eye. So all our patients are different. Some will settle the most within the first couple of hours. Some will take up to a week before they have that full settling effect. And remember, what happens when they settle, that lens gets tighter and tighter and tighter. So you have to make sure that you bring people back at these different intervals. And if that first visit when you see them is, after they've been wearing that lens after 4 hours, and you're not sure, hey, I'm not sure if I'm going to continue to get more settling, have a later appointment with them where they've been wearing the lens for 6 to 8 hours so you really can see what that lens looks like, because that tightness around that edge, you really need to be able to catch, and you want to catch that during your warranty period so you can fix all those changes before you give them this lens for the next year to take home.
Yeah, you're so right. The analogy I like to use, which I hope to share with the group today, is I oftentimes describe to a patient a scleral lens you can compare to a good pair of shoes. And just like every shoe, every brand has a certain fit and a size. You wear your shoes if they're comfortable. And it's our job to make sure that the scleral lenses are comfortable for the patient. But if the patient wiggles their toes, they know their shoes are on. And same thing with the contact lens. If the patient blinks, moves their eyes on, they know that the lens is on the eye. But the goal is we need a comfortable pair of shoes, and we need a comfortable pair of sclerals.
Absolutely. So the next topic that we're going to talk about is why and how to take photographs. This is a really great quote that Avani found. The whole point of taking pictures is so that you don't have to explain things with words. I don't know if you've ever had to do this, but in paper charts, having colored pencils and drawing things and all of that we had to do, we don't need to do that anymore. We have the ability to take photographs, which save us so much time, energy, and effort. And what we get in a photograph is no way what we can explain in words. Some of the key baseline images that I take with all of my scleral lens patients is, for sure, I'm going to get a baseline topography. I'm going to do pachymetry. And I'm fortunate that I have an OCT and I have this incredible function where I can take corneal pachymetry. So it gives me an image of all of the pachymetry readings all over the cornea, which is so useful, because the key of me taking any of these is to make sure that I'm not doing any harm, and I have a good way of tracking to make sure that I'm not doing anything with these corneas and not causing any problems with the sclerals that I'm putting them on. Obviously, I want to get good slit lamp images of what their cornea looks like before. I never want to question, hey, is that bit of neo, is that new? Is that something that I've created? Is it because of the lens, or is that something that's been there? We're not dealing with the cornea, but you have to take a look at the retina. The retina is important because you need to know what's the baseline. And people get referred to me for scleral lens fittings. And I always do a baseline OCT of the retina to make sure I know what's happening back there, because I want to know what I'm dealing with from a VA perspective. If something goes on, I need to know what happened before, after, so I can have all the pieces of information to really, really get good understanding of what's going on. Avani, is there anything that I'm missing here that you do that?
No, I think you actually said it perfectly. And I think, like you said, it gives you kind of a sense of confidence as a provider, but it also enables a little sense of trust from your patient when you're able to show them these baseline images so that they can see progression over time. I think the beauty of taking photography is also being able to monitor disease progression or regression and the therapeutic success. Oftentimes we fit scleral lenses, and it's because we're managing some type of corneal pathology. And like you mentioned, we want to ensure we're not doing any harm, but also the goal is that we use these images to help us troubleshoot. It's a great tool to communicate with consultation teams, and also for you to learn as a provider as you work with every single different type of patient. And the goal in discovering new findings is also being able to document. For many that know me personally, I'm not very well when it comes to describing words, but for me, documentation is a great way because a picture tells 1,000 words, and it does the easy part for me. So if we move on to this next slide, thanks to Dr. Kwok and Carrasquillo over at the Boston Foundation, this is a great example of why imaging and photography is so helpful. Both of these are examples of patients where baseline photos were done, and the patient was followed for years and was fit with the scleral lens device. And ironically, what they realized over the years, and we've learned as a community, is that scleral lenses can help not only therapeutically, but cause disease regression. And we have these beautiful images to show how corneal scars and vascularizations have completely regressed. And if we didn't have those photos, number one, we wouldn't be able to monitor it, but two, there's such a beautiful wow effect for your patient as well.
It makes it so much easier instead of you looking and going, does that look a little bit better? Does it look a little bit worse? Isn't it better? Because we both have had cases of this too, where we have seen improvements of corneal scars with scleral lenses. And I wish I had my camera years and years ago where I could have been able to take these images, but this is beautiful. And this is a prime example of where photography really comes into play. So I had a case where this man, he came to see me post PKP, had a corneal transplant in his left eye, and he needed to be fit with a scleral lens. And we were sailing along beautifully with this fit. And then all of a sudden his VA drops, and I had no idea what was going on. So I start looking, take the lens off, first of all, and then I start looking at the cornea, and I notice right away that the cornea looks a little hazy. So I check the cornea, I check the retina, and I did have corneal edema. And that initial corneal edema was able to be seen, yes, on the slit lamp, but I also had the ability to document and see how much of an elevation did I have in that cornea and how much swelling was taking place. So that way I could then continue to monitor and progress and watch as I was treating the cornea, was I returning the cornea back to normal? We solved the corneal edema, continued with our fit. A little while later, he started to have a decrease in vision again. And I went back and I looked, I'm like, the cornea is clear this time, what's going on? And thankfully I had baseline OCT images, and I rescanned his OCT and looked at his retina again. And then we started to deal with macular edema. It reinforces my reason for always checking the retina, because even though we are corneal specialists dealing with scleral lens fitting, the eye is a structure, has so many components to it that we need to not forget about the other parts of the eye. This guy was unfortunate that we had 2 episodes of edema at 2 different locations. I'm happy to say now he's doing really well, and he's well adjusted to his lenses, and we've got him all sorted out. Taking photographs. Okay, so let's dive into this section. There's so many different ways you can do this. Just using a smartphone, one of the really great ways is you can just hold them freehand, like I have in this top picture here, where we're taking a look at a patient. To get a good photograph with your smartphone, you want to have it set to about 2 to 2.5 times magnification. You want to have your flash on, and roughly about 3.5 to 4 inches from the eye is the ideal position where you can line up your camera. This is really good for telemedicine as well. If you want to have your patients and you want to teach them how to take images of their eyes to send you, they can use this exact same technique, except they are looking in a mirror. So we have Dr. Gellies down here who's demonstrating how to take a selfie for his patients when you're doing telemedicine. Other ways you can use some of the tools that we have in our office, I use my 20D lens and hold that up to the patient's eye and then use my smartphone to try and take images that way. It's a strategy that works. I also have this 4x magnifier that has a blue cobalt light on it. I really love using this because one, for my patients' parents, when they are in the room and they want to see what I'm doing, they come and look over my shoulder and see what I'm seeing, and they can see that eye in a magnified view. But then I can also grab my smartphone and then take an image through this filtered cobalt blue magnifier as well and get some good images this way. Another way that you can use your magnifier or your smartphone freehand is literally just hold it up to the slit lamp through the ocular and use that to grab images that way. It's not easy because you have to have a really steady hand and you've got to be able to position everything and, you know, get everything just right. Also use your tapping to get things into focus and then hold it in place. It's a little bit tough. And I think Avani has some better ways to use the slit lamp on a smartphone.
So I've tried your technique, Shalu, and for me, with my shaky hands, it just doesn't work. I'm surprised I can still hold a 90 in my hand without moving, but you end up with 50 photos and you only end up using 1 or 2. So I highly recommend for those that can, especially with now in this day and age, we're all at the mercy of our cell phones and our smartphones, to really investigate an adapter. There's so many different adapters that are available on the market. They tend to be phone specific. So if you're not an Apple lover and you prefer your Androids, that's okay too. You'll find something that fits your device. The beauty of the adapter is it tends to attach to your ocular of your slit lamp. It does typically attach to only one ocular. The opening of the adapter lines up with the single lens of your camera, which then lines up with your ocular. So while this works great for those one camera lenses, nowadays technology is just growing, and now we have iPhones with 3, and God knows 5 years from now it'll be 5 lenses. So that's the device that may not work as well for these adapters. Oftentimes you can also rock the camera and the entire adapter front and backwards to widen your view. And the beauty of these adapters is they're economical. So really going on a resource like Amazon, which is really available across the world, and the beauty of investigating what's going to work best for you and understanding what's going to fit not only your device, but also your slit lamp.
This image here at the top, this is of our second exam room, and this device, it's called Hookups, that we got on Amazon, and I think I paid $30 or $40 for it back in the day when I got it. And I bought a used phone that I kept in the office that was specifically meant for this setup. And I have used it for years and years and years, and it's only until recently that I got a new camera for the new office. But they work really well. And that technique of rocking, it's such a game changer. When you just lift the bottom of that whole device forward towards you a little bit, it can open up and give you such a much better view of the image that you're looking at, for sure.
So we talked about office setup, and as you all are familiar, I travel quite a bit. So in Buffalo, I work in an ophthalmology setting, and we have a main hospital location and 3 other satellite locations. And so I wanted to really highlight to the audience what my office setup looks like. And to be frank, it's different in every office. So in our downtown location, we have an imaging suite, and we put in orders for slit lamp photography. So I am at the mercy of our technical imaging staff who take the images for me. There I have to really be specific and communicate how I want the images, what I want the images for. So really communicating and training your imaging staff, if you work in a setting like that, is important. We have a Nikon camera that's attached to a slit lamp. So I love working at this location because I get beautiful photos that I oftentimes get lost in looking at, because you can capture so much with these photos. At another location, I use the ISLA device made by Augmented Vision Labs. And thanks to this group, I had 2 adapters that were designed specifically for my 2 exam lanes. I have a Hagstry in one slit lamp room, and then I have a Zeiss in the other. And so both oculars, the measurements are different. So these devices are specific to each ocular, and it's an easy clamp that comes on and off. And so I'm able to move around without having to move my patient and going to a different floor for imaging. And then lastly, I really like the utilization of big, large screen TVs. At one of our locations, we have a camera system, but also a videography system. So really taking a film of your patient's image can capture a lot of movement. And there's the beauty of why videos oftentimes give you more information than just still images. But the reason why I also like these large flat screen TVs is for patient education, really being able to capture that image and then replaying it so that you can educate, whether it's your patient in their chair, their parent, their significant other, their caretaker. And I also think it's a great education tool for staff or students like I work with at the University of Buffalo. So all three setups are different. And for me as a provider, it's important to be adaptable. And I'm able to acquire great information using a variety of resources.
So just recently, and I want to say maybe 4 weeks ago, it was my birthday and Christmas and every festival all rolled in one. It was the best day in our office. 12 years after having our practice, we finally got a slit lamp camera. And I can't tell you how happy I was to have this. I don't know why I didn't do it sooner, but I'm telling you, the process of finding this slit lamp mounted camera was so fun. I learned tons. And two of the top sort of competitors that came to mind when I was trying to make my decision was looking at the Hog that's attached to a Hog slit lamp, or the Marco Ion. It's a universal camera adapter that can be attached to many different slit lamps, and it's designed to work with an iPhone. The Marco Ion camera device is a wireless device that's used using your network, using Wi-Fi, whereas the Hog system is a wired system. Both are very different units altogether, but when I was looking for a slit lamp mounted device, I ended up actually choosing the Hog ultimately. And for me, the reason for it was, my big concern was that I didn't know how long my iPhone was going to last. And I was worried that that particular mount one day would not fit the particular iPhone, because, every year they keep coming out with a new design. And so I was worried about the longevity of the Ion device, which is why I ultimately went with the Hog. But the image quality of both of these devices is just phenomenal. And it's, like I said, it's one of the best gifts that we have gotten in the office. And I'm so happy to have this. I'm going to show you what our office setup looks like. We have here the main laptop computer that we use, and then we are able to project everything onto the big screen. And looking at the screen this way, when we're sitting with a patient, you have the camera attached here and then the big screen there. The primary reason for having that screen, one makes it really easy when I am taking photos. I can look over and see, am I in focus? Am I getting the image that I want? And I can quickly adjust and make adjustments and take images that way. And then I can take the whole device away, the slit lamp away, and show the patient. And when you talked about education, it's the most important thing that we do on a daily basis is we are educating and teaching our patients about what we're doing for them. And the more that we can show them, the easier it is for us to be able to explain what it is that we're doing and why we want the things that we want them to do. If we have a patient that has blepharitis and we need to explain hot compresses, or we want to do a BlephX treatment on them, this is the best way to convince them of why they need to be doing it. Because when we can show them that Demodex on their lids and lashes, that there's no other proof that you need. And so having an ability to show them this it's been a game changer from an education standpoint.
So this is a great resource that I must give credit to our residents, our ophthalmology residents at the University of Buffalo. They discovered this app called the Almond Indirect, and to be frank, they use it when they're on call overnight and it's 2 a.m. and they want to show a fundus image or a video to their attending of a retinal detachment or a tear. But the unique component of this app is that it actually has a slit lamp mode. And I've utilized it myself. I think it's perfect to use because it has a focal point, an exposure, and a light setting that automatically adjusts. So you have a lot of features that you can actually manipulate within the app rather than opening up just your camera of your iPhone or your smart device. The other reason why I really like this is I'm guilty of unsteady hands. And so this application really gives you a video. And so as we know, dynamically, there can be a lot of movements. The video is able to capture a lot of information, and on a provider level, whether it's fluctuations in the quality of the image, to even just looking at fluctuations on how that lens looks like on the eye. Also, the video can be shot in various lengths, and you can really break up the videos. My recommendation is to keep them short and sweet, so 10 to 15 seconds is perfect. And another reason why I really like this is because you can share this with your consulting team, including the ones at Boston site, and I find it very helpful to really further describe what you're looking at in the chair and how to manage some of your fitting complications.
The one thing also, I don't think I heard you say this, but this app is free, so you don't yeah,
forget about that.
Good. It's really, really easy and really great. Yeah, being able to share things with consultation, it's kind of comes down to that words, right? When you're trying to describe what you're seeing, when you can send a photograph or you can send a video of movement, or it just makes it so much easier for that consultant to be able to help you redesign and fix your fit.
Absolutely.
Okay, so we're going to dive into a few features of how to improve the quality of your images when you're taking images. And, you know, this topic is, I find it really funny. When we were talking about illumination, and, you know, I was having a conversation with Avani, and I said, you know, when we think about our slit lamp and we're looking at the cornea and we're looking at all these things, I'm not thinking about whether I'm using diffuse light, direct light, retro illumination. I'm just doing a slit lamp exam. And we were joking it about all the different features of our slit lamp and how complex they are and how great they are to be able to look at different aspects of the cornea, to be able to look at the fit of the lens while using an optic section, while using indirect light, while using retro illumination to see different shadows. And it's funny because I just don't think about these types of details about the illumination. I just dive in and start doing my slit lamp. I think the big thing is sometimes when we are using our slit lamp, we tend to focus in on small details. And the key thing that we need to remember is to take a step back and get big, wide views and make sure we do have global views and not just focus on those parallel pipe scans and going across the cornea, because you will miss things that way. How about you, Avani? Tell me more about how you're doing.
I was going to say is that, you know, it's all of us have been through a period where we were learning slit lamp 101 and really holding your light source at 45 degrees and moving it and changing the different heights and beams. And now it becomes part of your muscle memory that you don't think about it. But I think you hit the nail on the head, is that really manipulating your light, your magnification and your beam heights can really influence quite a bit of what you're evaluating. I think this is a perfect segue to go into diffuse illumination. I really utilize diffuse light when I'm looking at the conjunctiva and seeing what the scleral lens is doing. And so really, I think the one take-home point is learn your slit lamp. Depending on what model of the slit lamp you have, you might already have a filter that's already put up in there. So these are two images of my Hog versus Zeiss, where I have filters that just simply flip up and flip down. There's also the unique trick of taking plastic tape and just taping it over your slit lamp light source to create that diffuse beam. And third is I want to give credit to the Contact Lens Spectra in the recent May 2021 issue, where using this trick of putting a small plastic cup over your light source, something like one of those small medicine measuring cups, works great. And really that creates a perfect diffraction of light and gives you that diffuse light that you're looking for.
When it comes to lighting and filters, you know, you described it perfectly about playing around and testing things out. You know, I have so much fun with this because you get to become a photographer and you get to experiment with different lighting situations. You know, when we look at cobalt blue versus using a Retina filter with the cobalt blue light, you can see this is the exact same cornea, moments apart. And what you can see with that Retina filter, you can see that you can see more damage that's done here, that SPK on the edge of the cornea that you just can't see with that cobalt blue light. So playing around with filters is really important. My Retina filter is on my slit lamp table right next to me at all times. Here, down here at these two photos, on the left, we have that image of the cornea that we're seeing through the smartphone. And this is with the slit lamp light on. What I then did was that I turned off the slit lamp light and turned on the room lighting to get a picture here of the same cornea with just ambient light. And that room light gave me such a different perspective on these images. And you can play around with the lights in the room being down, up, slit lamp on versus off, and see what type of images you get depending on what it is that you're trying to photograph. These two pictures up here, this photograph right here on the left has the slit lamp light shone right on this papilloma, and you can barely see it. And one of the things that came with our Hog slit lamp mounted camera is a backlight illuminator. And so this is an additional light that attaches to our slit lamp that we can bring off to the side and shine onto the cornea. And you can see by using that background illuminator, what a difference this picture quality picture has given us, where we can see that papilloma so much better. And it's so great for us to be able to have these baseline images to, one, be able to track size and change over time. But again, just playing around with the different filters and illumination and brightness, room lighting is really important.
I agree with you. And I think practice makes perfect is continuing to practice some of these skills. Magnification also plays such a huge role. I think as providers, we're so honed in on the details that, as you mentioned earlier, what I personally like to do when I'm evaluating a scleral lens, especially for a patient that's coming back for follow-up, is I crank my magnification all the way low. I want to look at the big picture first and then hone in on the details. And so really, as you can tell just on this slide, the various magnifications are going to give you such different pieces of information. And oftentimes I find if you're only working on one magnification, you're going to miss another part of the picture. So the goal is to continuously spin that dial for magnification. I think this is a great example to really summarize how illumination and lighting using different beam heights or types of beams and magnification can give you different information. So if you're looking at your corneal vault, you're going to look at a very high mag, increased illumination, really tight optic section, using your filter to look overall and assessing your fluorescein pattern, and then using nice quiet diffuse light on lower magnifications to look at that overall picture of the scleral landing zones as well. So practice makes perfect. Take those photos and you'll learn and get better. We're not photographers by trade, but I think we know for a fact that it definitely helps us improve our skills the more we capture these images.
You know, we have talked so much about OCTs over this talk, but we have to remember how powerful our slit lamps are. They provide so much, and we can manipulate them in such ways to get so much detail. You know, I fit scleral lenses for 10 years without an OCT. So you don't need an OCT to fit scleral lenses. So please don't take that away from this course, that, you know, your slit lamp is so powerful and you can do so much with it, with just changing your magnifications, using filters, changing your beam widths, and really playing around with different filters for sure.
Absolutely. So Shalu, we've talked about how to take a picture, but then the big question is how do you save this? And we know that in the day of technology, and I am not like a computer scientist by profession, but there's so many different options on how to save an image. The one take-home point that I will say from my own practice is I would take a beautiful image, and when I would save it, oftentimes, depending on the size of my image, if it compressed the size rather than the actual image size, I'd lose a lot of clarity where the images would get pixelated. I'd lose some details or the sharpness. So if, when you can, keep your original image size, because that detail is crucial. Also, we know that Adobe PDFs or JPEG images, for example, are the most universal across various systems, but I think it doesn't necessarily give you the detail that you're looking for compared to PNG files. But unfortunately, PNG files are massive in size. So really assessing what your storage device is going to be, whether it's your EMR, whether you have an external hard drive, so you can really keep these images and utilize them and hang on to them for future reference. I think for printing purposes or lecturing purposes also, TIFF files are also beautiful because of the clarity and the contrast of the colors. But really, I think the moral of this slide is understand what image size is going to work best. Try to keep it consistent also when you're comparing different images. And third is make sure you know how to access your images, because the last thing you want is to share these images and then there you go, you lost a file and then now it's corrupted.
Yep. Parallax. So parallax is something that I just want to bring up so that you know to look out for it and watch for it. Parallax happens when either you are looking and so this is kind of tricky to explain, but it can happen when you're taking an image and the image that you're looking at looks shifted in the actual photograph. And it happens sometimes when there's movement in your camera with your shaky hands, Avani, or when you are looking through an ocular, maybe with one eye and you're taking an image with the other eye. You know, when you're looking at an image and you're looking at it and you look through with your dominant eye, you've got that image, you cover the dominant eye, and then that image can shift, kind of like what this image is showing you down here, where the non-leading eye is not focused on the exact same thing. Think of something similar like that can happen in a photograph. The most important thing to know is that when you are looking at something through the slit lamp, take your image and then look at your image to make sure that everything was aligned correctly. So the placement of what you're looking at matches in the photograph to what you're looking at. Because the shifting of items and things in the photograph can happen, and that's what parallax is. And you just don't want to get confused with a photograph and say, why is this here and it now looks here? That's the only thing to this, is you just want to make sure that this is something that you have to watch out for and make sure that your photographs do represent what you're actually looking at through the slit lamp.
Yeah, I agree. We've all taken photos and then looked at them and kind of had a question mark in our head. And I can tell you the same applies for this concept in vignetting. Shalu and I have both been laughing about portrait mode and how we all use it on our iPhones. And really with portrait mode, the beauty of it is that it blurs out the periphery of the image so you can really focus on the center portion of your image. But this can oftentimes work to a disadvantage in the real world of scleral lenses. So this is a perfect image of a scleral lens that's causing impingement on a pinguecula. And I held up my slit lamp or my iPhone to my slit lamp ocular and tried to take the image. But a lot of the periphery of that image is artifact caused by the actual ocular. And so while I do have this beautiful area of blanching and impingement over this pinguecula, I'm kind of losing it because of how much wasted space I have due to that ocular. So really, the goal of vignetting is to highlight the central portion of the image, but the goal is for us as scleral lens providers is every point of your image should give you valuable information, and really increasing your magnification and adjusting yourself to really eliminate this peripheral artifact. Of course, as long as you're not taking a portrait image, right, Shalu?
Right. So let's dive into some cases. We've got just a couple of minutes left.
Yes, absolutely. I think this first case is of a 67-year-old female that wore many different types of lenses. She was diagnosed with keratoconus since her 20s. And I met her because she was very motivated to be refit into, or to be fit into scleral lenses for the purpose of her dry eye disease. So I opened up my 18mm set of the Boston Sight Scleral. And for those of you who are just learning to how to fit the Boston Sight Scleral, Karen's going to introduce you to some great resources. But if we move on to the next slide, what you can see is really choosing your diameter is your first step. So once you choose your diameter, you're starting with a standard lens and really evaluating exactly what we talked about at the beginning of this lecture is your central clearance, and then really determining whether your haptics are too tight or too loose. And then you're simply just moving up side to side, depending on the distribution you're seeing at your slit lamp. So with this patient, I fit her with both the right and the left side. If we move on, actually, Shalu, to the next page, what we can see is I kind of chose two different lenses in the end. For her right eye, I went to a little lower sagittal height. For her left eye, I stuck with my standard lens. And with an over refraction, she was 20/20 and very happy. So I went ahead and logged on to my Fit Connect. I utilized my diagnostic lenses, brought them up, and made some minor changes. This is a demonstration of the beautiful graphical program that we have on Fit Connect, where we can look at each individual haptic. There were some adjustments on the right eye where I flattened my meridian 2 and 3 by 350 micron steps to a total of 150. And the beauty of this Fit Connect program is you can actually visually see the change that you have. So you have your change lens, which is illustrated by the red line, and then the blue, which is your original diagnostic lens. And I also believe I think steepened up her mid periphery too to shave off of that mid-peripheral clearance. So she picked up her lenses, she went through INR training, and eventually I saw her back when she had well adapted to the lenses. She was wearing them 14 hours a day. She was all excited. Dr. Dave, I love these lenses. They're comfortable. What a difference. But the one complaint she had was at the end of the day, she felt like she was fighting to take the lenses off. Lenses felt suctioned onto the eye. And when she did finally remove them, her eyes would be a little red for a few minutes. And so really using OCT images, I looked at the central clearance, really nice low central clearance. I utilized a ruler to really determine how many microns I had. And then I was looking at the edges, and really these pictures are twofold benefits. I do want to draw everyone's attention to the fact that the patient did have some hybrid lens related neovascularizations. So these photos were very, very important for me to monitor that neovascularization at the limbus. But when I look at these haptics, I don't know, Shalu, what do you think? How do they look?
To me, looking at this, they look great. What I would want to see is a little bit closer. I want to put some dye in here. I want to get more into it. I want to increase the magnification, see what's going on top and bottom, and really dive in a little bit more.
You know, and it wouldn't be a great case if I actually gave that to you, right? So I did instill dye. She had very slow tear exchange, but she did have some, so that was great. I knew that the lenses weren't suctioning off completely. This was her superior scleral alignment. But then one thing I noticed inferiorly was I had this congested appearance on both eyes inferiorly with very mild conjunctival prolapse. And then using my optic section and increasing that magnification, what I realized was my inferior limbal clearance was a little higher than I preferred. And that was also creating partly this dragging of that conjunctiva, which we often describe as prolapse or bogging. And so in discussing really this case, and thinking about the changes I wanted to make, I knew I wanted to flatten out my haptic and really relax that inferior edge. I needed to bring down that limbal clearance, but then what to do about this suction is really just making the adjustment enough, or do I need to think about adding a fenestration or a channel? And thanks to the team at Boston Site, what we decided to do was introduce 2 channels for this patient on both of her lenses. So the channels I made about 20 degrees wide, and I kept them about nasal and temporal, and they were also about 200 microns in depth. The goal was I didn't want to make them too deep where then we'd have a source of fogging or an influx of debris. And with this, the patient came back with her new lenses happy. The conch prolapse receded. The limbus looked nice and even. We didn't have an increase in neovascularization or any staining, but the best was me really getting a feel. When I removed her lenses, they came off very nice and easy. And so I think the channels and this technology, the smart channels that Boston Site has, is a great resource for a lot of our patients that really have this suction issue. What the images really taught me was to evaluate my complication with her fit, but also to monitor her long term, especially with that neovascularization. I think it's important to really evaluate long term how this patient's going to be doing. So great resources with between using Fit Connect as well as using my imaging.
Okay, we've got like 1 minute left. I'm going to zoom through this last case. There's this beautiful 62-year-old female. She has gone through so much in her life. Her left eye, she had LASIK in both eyes. She had a retinal detachment. Then she had cataract surgery. The lens got dislocated. She had to go back in and have that surgery repeated. She's had bullous keratopathy, so much scarring, and had multiple epithelial defects on this left eye. There was a thought that she had HSV, so she had to have that tested for. She was on treatments for HSV until the test came back negative. She had 2 amniotic membranes to try and fix these epithelial defects. She was put on Oxervert for a while. She was then put on bandage contact lens. And then she came in, she was like, this is not getting better. What do we do? Okay, with all of these artificial tears and ointments that she was on, we decided that we were going to put her into a contact lens, a scleral lens. So here's a good photograph of what she looked like before we started her treatment. You can see these epithelial defects. You can see where she's had her LASIK done. And I want to show you what she looked like after we put a scleral lens on. We put her in the 18mm Boston Scleral lens, and we did end up putting a channel on this lens on the nasal aspect. Remember, she had a retinal detachment, and the anterior segment of the buccal, the anterior buccal, was creating a bit of an elevation. And so we needed to put a channel on this lens in order to vault over that area to give us a better landing and to give her more comfort. And at the 2-week follow-up, we can see that we started to notice some improvement, even more improvement after 4 weeks. What's nice about this is you can see with the photographs, we're able to see the progression of the improvement over time. And we can see that with everything that she tried before, she was not getting resolution, but here we are able to photo document that she was actually getting improvement in resolution with these scleral lenses on. So you can see now this is about 2 months after she's been wearing the lenses. And you can see here the difference when we first started and once we are near the end of our fit here. I have seen this, Avani, I know you've seen this time and time again, where the therapeutic benefits of what scleral lenses can do on corneas, where people have given up hope and said there's nothing else we can do. I have seen it time and time again where scars have improved, where vision has maximized even after 6 months, a year later, 2 years later. They're seeing better than they did even with their initial lenses, because that nourishment of that fluid on the cornea just keeps healing the cornea and keeps healing it. And it's incredible what scleral lenses are able to do. With that, Karen, I'm going to pass this back over to you.
Wonderful. Shalu and Avani, what a great presentation. Thank you so much. You know, we know that last year, 2020, was a really hard year, but, you know, scleral lenses shouldn't be difficult too, right? And with all these great tools that you've provided, especially mastering the art of photo documentation and how these can actually help us, right, manage our patients. And as you have shown, really monitor your treatments is super helpful. So thank you both very much one more time. And, you know, for the audience, if you want to learn more about Boston-sized scleral features, including a little bit more about smart channels, which were discussed today, but also if you want to learn about our smart side technology and our freeform Smart 360 technology, just go to our website, bostonsizescleral.org. And also, you know, inviting you to join and follow us on the different social media platforms. We have a great Fit Group page where we discuss really great cases for educational purposes. And so with that, Avani and Shalu, we do have quite a bit of questions. There's a lot of interest, which is great. So if you don't mind, we can probably take like 5-7 minutes. You know, I know we're past, and entertain some of these questions. One question that I had, I love the cobalt blue magnifier that you had, Shalu. We used to have one of those in the clinic, and I found those to be so helpful for pediatric patients. We currently have a Burton lamp, but where did you find this? Or where can we find this?
Yeah, it's a really good question. I got that. I was a resident at the time, and there was a doctor in the Netherlands that I reached out to and contacted and got it from him. I'm going to see if I can try and track down where I got it. That magnifier is a regular magnifier that you use for low vision, but it had that cobalt blue attachment to it. So let me see, Karen, if I can find it for you, and I'll get some more information back to you.
I mean, it would be great. I mean, we couldn't find, but, you know, also for the audience, as I said, you know, we do use the Burton lamp. And one comment about the parallax, you know, I don't know if you guys experienced it. I think that's a great tip that you provided to our listeners, because in order to monitor progression, we really want to avoid parallax. And one tip and trick that we have adopted at our clinic is that we make sure that we position the flash. We bring up an old photo and we see where the flash was positioned in the eye, and we try to match in the new photo the flash in the same position, so that we can really make comparisons and avoid that parallax issue. So very good. So we have few questions. Quickly, someone here is asking, how do you manage conjunctival prolapse? You did touch upon that. I mean, can you just quickly remind the audience of how you do, both of you tackle this
Yeah.
finding?
I think, conch prolapse is such an interesting discussion because the question is it really a problem? For me, I find that conch prolapse is something that I really manage by lowering the limbal vault, in reducing suction, and seeing how that in landing zone is really impacting the prolapse. But honestly, sometimes I find that it's inevitable, especially with those loose conch chalasis eyes. And so what I'm really looking for is when I remove that scleral lens, is the prolapse receding? And do I have neovascularization or any type of microcystic edema at the limbus? And if I don't, then by theory, to me, that's not necessarily a problem. But I don't know. What do you think, Shalu? What do you do?
No, I agree. So I'm reducing the limbal clearance to make sure that I'm getting rid of that negative pressure. It's that pressure underneath that lens in that area that causes everything to be pulled up. So if I can get rid of that, loosen things up a tiny bit. So, bring that limbal clearance down a little bit, then that leaves that conj from coming up. But the key thing that you mentioned is making sure that there is no neovascularization that's present at all. If you have a tiny little bit of conj prolapse that's not encroaching onto the cornea too much and there's no neo, leave it, but you have to watch it and make sure that you don't get blood vessel growth and there's not this irritation that's happening. So I do my best to reduce it by reducing and adjusting the limbal clearance using channels, and really bringing down that area, bringing down that negative pressure, but just watching is really important. And that's where the photo documentation comes into play too, to know, okay, when I started with this cornea, do I have any clear neo or not? And it's not neo on top of the prolapse. You have to take the lens off and let the conj settle and make sure there's no neo on the cornea. So that's where you want to look. You're not going to see that neo through the lens. You have to take the lens off and let that conj now slip back down so you can take a look at it.
I will also add with fluorescein too. Sometimes when you strip the fluorescein and there's too much solution in the eye, you'll oftentimes miss staining or miss microcystic edema that'll develop. So oftentimes what I'll do is after I apply some dye, I'll let some of that dye drain, and then I'm looking at the limbus to see what exactly it's doing. If you over flood it, you're missing a lot of valuable information too.
I do my initial scan, I look, and then I'll go and take my notes. I'll be like, just give it a couple of seconds, give them a Kleenex, so dab the rest of the extra. A couple of minutes later, I'll go back and take another look and bring that Ratten filter out to make sure I'm not missing anything.
Wonderful. Thank you so much. That is super helpful. An attendee just noted that they looked at the App Store and they couldn't find the Ullman indirect, and they're wondering if is it available in Canada?
It is unfortunately only available in the US at the time, but I was informed that it should be available on other platforms coming soon.
Okay, wonderful. Where can I find the holder of the smartphone to use on the slit lamp? Is it mainly Amazon? Do you have any other resources?
I got mine from Amazon and I did a quick look. If you do microscope adapter, it'll give you a whole bunch of them. The particular one that we showed is called Hookups, HOOKUPS. And I think it's like $40 or $60 for that one. There's a whole bunch of different ones that you can try, and they're designed for microscopes that, like Avani mentioned, you just place them on one ocular.
Right. I want to also recommend Augmented Vision Labs too. The ISLA device is what I use at one of my clinics, and they're the provider there. If you interact with them, give them measurements of your oculars, they'll specifically create eyepieces that are specific to your ocular measurements as well.
Wonderful. This is not a question, but it's a shout out. We have a practitioner joining from Ecuador, Dr. Vasquez. So he's saying excellent speakers and great tips. So he's thanking us. Thank you, Dr. Vasquez, for joining.
Thank you. Thank you.
So just the last question before we break, this is not about photo documentation, but there's a couple of questions. If you can each take about, very brief, like 2 minutes each, what is your top advice on how to manage a high volume scleral lens practice?
Shalu, you want to take this first and then I can chat about next?
Oh, how to manage a high volume scleral lens
Maybe
practice.
tips for scheduling. Maybe you can
Yeah.
just provide, you know, your how do you schedule your patients?
My best advice is to have really good team members to help you, because that is honestly the only way that I'm able to do as many fits that I do in the course of a day. When I first started, it took me so long because I was trying to do everything myself. I'm at a point right now where I have 3 team members that know everything about sclerals. Everything I know, I want to teach them so that they can do everything for me. Before a patient comes in, I've pre-planned what lens we're going to start with. They will put the lens on. They will check my OCT heights to say we have touch or we don't. And then from there, they will let the patient settle, and then I will see them. The time that I actually spend with the patient is in grand total, maybe 15 to 20 minutes. And even that time when I'm with the patient, my team member is with me, my staff member is with me, and I am dictating what I'm seeing and the changes that need to be made, and they are making notes for me. It's the only way I could go as fast as I could and see as many patients that I can, is by having those people there to help me. If I tried to do it all on my own, there's no way I would get it done. Even with my initial consultations, when I'm talking and introducing sclerals to a new patient to the office, I will introduce the concept. I will have 30 minutes with that patient. That patient is going to have tons of questions afterwards that I don't have time to answer. So I will hand that patient off to one of my team members who will then sit with them. And if it's for half an hour, 40 minutes, an hour, whatever it is that they need to understand, to demonstrate, to see what a scleral lens is all about, have all their questions answered, I'm telling you, I rely on them so much. And that's my biggest tip, to be able to go as quickly as we are.
Yeah, I agree. And of course, I practice at Shalu's practice. So I can say the support team is crucial, and we have a wonderful staff there. At the University of Buffalo, I run a very different clinic. So for me, I've allocated specific days to contact lens only patients. So I currently have my Monday, Wednesday, and Fridays to contacts only. So that means I'm not doing post-ops or glaucoma management or emergency retinal detachment triages. I'm really only focused on sclerals. As Shalu mentioned, I have 2 contact lens coordinators that are really managing everything from insurance to financials to appeals and really the logistics behind scleral lenses, because we know for many patients, acquisition is the hardest part. They know they want the service, but oftentimes it's access of how to. Second is the strategy that I use to schedule my patients. So we are a high volume practice. I typically schedule at least 1 hour for a new scleral lens patient. And then all of my subsequent follow-ups for them are usually half hour. We do have excellent support staff. So we have technicians that work up my patients. I have a protocol, a standard operating procedure where when patients are entering the door, there's about 6 to 10 different providers in the building at the same time. So if they know it's a Dr. Dave patient, this patient's getting an anterior segment OCT, they're going to the imaging department, they're getting their slit-lamp camera photos, and I'm really seeing that patient so that I have all of that data at my fingertips. And then of course, I'm fortunate that I have a scribe too. So oftentimes a lot of what I'm thinking or verbalizing is getting documented. So I think really having that 3-part of imaging support, technical support, administration support is key. And then the last you mentioned, Shalu, is consultation. So really determining whether it's emails or phone calls or ways that you manage the product. When you have a high volume, managing your warranties is important. Communicating with consultants is important. And I think that really having that team around you is key. Lastly, I'll say is I practice at so many different locations. So for me, standardizing it at every different location is important, because then what I apply at one applies to the next. And even though staff changes, standarding it is important for not only you, but for your patients that come in. You form a really close bond with these patients over their warranty period. And the last thing they want to feel is they're getting thrown through the ringer every time they're coming in. So I like to keep that standard protocol every time.
That's beautiful. And I couldn't agree with you more. We're in our clinic at Boston site, we're also very fortunate to have an amazing team and technicians and support staff. And without them, you know, truly, we couldn't really do everything that we're able to accomplish. So this is a great tip. We do have more questions, but in the interest of time, please know that we will follow up with an email to all the attendees, and we'll take the time to answer those questions for you. Thank
Absolutely.
you everyone for joining tonight. We're really grateful to have Dr. Avani and Shalu. Thank you for a phenomenal presentation. Thank you again, and thank you everyone, and have a good night. We'll see you next time. Take care.
Thank you, everyone. Thanks for having us,
Thank you so
Karen.
much, everybody.
Bye.
Bye-bye.